Wait a minute, let me just talk right now. What? Okay. All right, I think people are filing in. We'll get started with the kind of afternoon session here. So the first speaker for the afternoon session is an honor to have them here with us. It's Pat Juckem, the head coach for the WashU boys basketball team.
Sure. Well, absolute pleasure to be here, and I want to thank Siteman, Dr. Jin, everyone who was involved with pulling this together. As the men's basketball coach at the university, it is my life and experience has intersected with what you all do through a young man by the name of Justin Hardy, who played for us at WashU, developed stage 4 gastric diffuse stomach cancer in spring of 2021, and had kind of a remarkable story. Unfortunately passed away in May of 2022, and I believe we have a video kind of to introduce, and then I'll have some remarks after that, so let you see the video.
In every basketball game I've ever played, right? I'm not sure I've ever stepped on the court where I thought I was gonna lose. This was a game I was getting into that I didn't think I could win. But I think my definition of win was a little skewed. The first scar I got was from the perforated ulcer I had back in April.
You cannot be average today, and you should be bloody. You should be scraped up, okay? You should have holes in your jersey like Hardy does. Puts holes in every jersey that he has. You should just lay it on the line.
Second thing I got was this Metaport here. What is my story? Where do you even begin with that?
In 2018, Justin Hardy arrived at Washington University in St. Louis, a perennial Division III basketball power.
This is the 215-pound machine. And when I watch video of our team from 2 years ago, he just stands out.
He was the Rookie of the Year. He played like one of the best players in the country, and he was for sure going to be an All-American, no doubt about it in my mind.
But during Hardy's sophomore year in 2020, Washington's season was cut short by COVID. Then his junior season was canceled altogether. Last April, in the best shape of his life, he awoke to a searing pain in his stomach. Doctors discovered a perforated ulcer, performed surgery, and then discovered something else.
They felt very strong that they had observed signs of cancer. I was sure they were wrong. It just couldn't, I just figured they made a mistake and pathology would show that it was something different.
Doctor came in and she goes, I got the pathology results back. You do in fact have cancer. I'm sorry, this is probably the worst day of your life. There is no cure for stage 4 stomach cancer right now. And I'm being put into this game that I've, in theory, zero chance of winning. Yeah, give me 1 second.
The initial prognosis that he received was likelihood of 12 to 18 months after diagnosis for survivorship.
Beginning last June, Hardy underwent a grueling protocol of radiation and chemo treatments to battle the stage 4 cancer. In only a few months, those treatments had reduced the once 215-pound basketball machine to as little as 165 pounds.
He looked like a shell of himself. He couldn't move. He was weak. His voice was weak, and it just wasn't the same Justin.
We're our best version of ourselves when he's with us. Our hope is that he could just be here physically for his senior year. I didn't think there was a basketball future for him.
Hardy had other ideas. By October of last year, he was practicing with the team. By November, he was in the starting lineup.
Run away for Hardy. It's up and good. Justin Hardy.
By December, he was dunking.
Hardy down the lane strong. Jams it home from the free throw line.
And only a few weeks ago, he tied a career high of 28 points.
And it's made. Justin Hardy. What can't Justin Hardy do? Might take a while to figure that one out.
He played like the best player in the country. Yeah, I just smile because I'm like, I know what I'm witnessing right now is something that's probably never happened and probably won't ever happen again.
There was no piece of me that was going to half-ass this. If I was going to do this, I was going to do this.
Emory's playing some good defense here in the first half. Hardy, though, finds some room from distance, and he splashes one home.
With his family watching from the stands, the 22-year-old Hardy struggled to get through a recent game. His condition worsens each day, a byproduct of an unrelenting cancer that recently spread to the lining of his colon.
It's pills every day. It's treatment usually every other week, where he can't really feel his feet or his hands. He has other things that pop up that he won't even tell you about because that's just Justin, but it is every day for him, every single day.
I can't control the spread of the cancer inside of me, and that portion is going to do what it does, and it might be further away than I think it is, but it's definitely closer than I want it to be. This is beating it. This is me living my life regardless of the circumstances. If this isn't beating it, I don't know what is.
Standing of this remarkable young man in Justin, and I'm here representing his family, his parents, Bob and Karen, his siblings, Jackie and Nathan, along with the foundation, the HardyStrong Foundation that was founded after his passing. He accomplished so many remarkable things in his life, but his story truly is about how he consciously chose to live with cancer. A couple things once he got the diagnosis and once he grasped and processed it, he was intentional about a couple things. Number one, he gave up the idea of perfection. He was no longer afraid of failure. And he said, even if I'm perfect, the world around me is not. Even if I don't reach perfection, it's worth striving for. The second conscious decision he made was to eliminate negativity from his life. He chose to be, I'd never heard this before he said it, relentlessly positive. He chose to be relentlessly positive. Negativity could not consume his thoughts. He looked at all circumstances with an optimistic viewpoint. He set out a couple goals after his diagnosis. One was to graduate from WashU's Olin Business School. When he was diagnosed, it was in his junior year. He did that, he came back, he graduated a semester early with high academic honors. He had just secured an internship with McKinsey, and his goal was to complete the He completed the internship with McKinsey while he was undergoing treatment and got the return offer, which is amazing. And then his third is to continue doing what he loved to do. And as you can see in that video, it was to play basketball at WashU. You saw the effect of his treatments. We never would have fathomed, as I said on there, I just hoped that he could come back to school and be with us. Never did I think that he would actually play again. And the fact that he not only played, but he played really well I think it should be a movie, quite honestly. There were some times where he'd have treatment, like he'd be here in Siteman on a Monday and Tuesday getting chemo treatment. He'd come to practice and observe on Wednesday. He'd participate on Thursday, and then he'd play in a college basketball game on Friday, and he'd play really well. And it's still astounding even to say it. His story became a national story. That piece certainly helped get it out to the world. He started interacting with some of the biggest names in sports who were inspired by his courageousness and his positivity. And the national recognition that he received allowed him to share his story and positively impact countless others. I do have a story about his time getting treatment here at Siteman. He developed a close relationship with his oncologist, Dr. Haesong Park. Dr. Park had never been to a basketball game. I don't think she knew what basketball really was, but she was so intrigued by what this guy was doing that she came to watch him. And I think she brought an assistant with who knew a little bit something about basketball, who could kind of like interpret what was happening. But she was, I think, dumbfounded what he was doing while in the shape and going through the treatments that he was going through. But that personal touch, I know it meant so much. And just talking to his parents, Justin's parents here recently, again, they brought up that story, how much that he was cared for as a patient. He was more than a patient. And that really, really, really was meaningful for that family, for the Hardy family. After we lost our final game, so we lost in the NCAA tournament in March, and those are somber situations, right? Your season's ended. We had a bunch of seniors; their career's over. Justin's career was over. I always allow each of the seniors to say kind of what's ever on their heart, and Justin went last, and he thanked his teammates, and he proceeded to say the following, and it's incredible. He said, "Guys, this was my favorite year of my life." And it changed the whole environment from this sad to, wow, talk about putting it in perspective. And he said, the reason I got up every day was to come to be with you guys and to do this. And it was really something also that he became extremely others focused. He poured into other relationships, old ones, new ones, people we weren't even aware that he was interacting with in a time where he should have been so selfish. He was concerned about everybody else, which is just truly remarkable. And he uses this phrase that he chose to write his story from the front cover to the very last page. After Justin's passing, his legacy continues to evolve, and the impact grows daily. The HardyStrong Foundation was started in 2023 with a three-part mission. The first, to increase the awareness and support of hereditary diffuse gastric cancer. And I can say, just having the chance to interact with Dr. Guilford, thank you. Thank to all of you that are part of this, tackling this and attacking this on the front lines, but to have a chance to meet Dr. Guilford, know that the foundation is very supportive of his work and will continue to be. Second, to provide resources and improve access to genetic testing for cancer risk. And finally, to honor the legacy of Justin through scholarships for exemplary scholar athletes. In less than 3 years, the foundation has awarded numerous scholarships to graduating high school students, has supported researchers in the front line of stomach cancer research, and has begun partnering with companies involved with genetic testing. While we are all devastated by his loss, his impact is evolving and undeniable. Thank you for the opportunity to share his story, to share his legacy on behalf of his family and the foundation. And just know that we're humbled and we are excited about the future and supporting the great work that's being done. So, thank you.
It's difficult to follow that up. Of course, that's very impactful. We cannot thank you enough, Coach. And of course, to Justin's family, it means a tremendous amount to everybody. So no more comments. The next up we have is Julie Richison, a social worker, who will kind of go into some of the details of that aspect of cancer care for our patients and their families. And Barb, of course. Sorry about that. And Barb.
Boy, that's going to be tough to follow. What a story about courage, and I had heard his story before I started working at WashU, and it gives me the goosebumps every time I hear it. So thank you so much for that. Barb and I are here today to talk a little bit about some social work resources that are available to our cancer patients. We work in the satellite offices of Siteman. You know, as you guys all know, there's the main building, and then there's West County, where Barb works. I work in the Illinois side, so I work over in Shiloh. So there's a vast difference between Illinois and Missouri, which we'll see a little bit getting into some of these slides. But what we're going to talk about today is just some of the services that we have available. There we go. One of our main roles is to help, the patients, families, and caregivers to cope with the distress, the challenges, a lot of things that come up with cancer diagnosis and treatment. You first hear that word, cancer. It's pretty overwhelming. I can't tell you how many times we get patients that come in, and it's like they had a they found a tumor, they had a biopsy, they went for a CAT scan, they had a PET scan, they're meeting with an oncologist. All of a sudden, the oncologist wants them to meet with a surgeon. They're meeting with a surgeon, they're having treatments. So we get them when they're at their most vulnerable. So what we try to do is we try to help remove some of the barriers to the treatment and to provide them with a lot of not only emotional support, but also some emotional transportation, just a lot of different support that they need. And during the visit at Siteman, you can ask your doctor, nurse, any care member to contact a social worker for you. And we have social workers available on site every day. Now, like today, Barb and I are both here, so we both have somebody covering remotely for us. So if we're not on site, we always have somebody available, Monday through Friday, or, during regular business hours. And next. Okay, you did that. There we go. One of the biggest parts of the social work concept is to get to know our patients by a psychosocial assessment. The assessment was kind of hard to put on the screen because we tried to fit it into one page. But when we're typing, this is almost 5 or 6, 7, 8 pages long. So what we did is I developed this thing where it's almost verbatim of what the assessment looks like. It goes anywhere. We want to know their name, their MRN number, because, sometimes we don't put their name, but we'll put their MRN number for privacy. What is their diagnosis? Who is their doctor? Just real quick things that we can take a quick look at. Are they alert and oriented? Do they have a power of attorney? That's a very important thing, because as they go through their journey, we want to make sure who can we contact if there's somebody if they're not alert and oriented. Do we have any concerns about abuse? It could be physical, emotional, neglect, anything like that. Are we concerned about domestic violence? If so, what kind of services did we refer them to? Did we refer them to, like in Illinois, they have the Domestic Violence Center. Missouri also has some services. Who do they live with? Do they live by themselves? Do they live, with their spouse? Is their spouse supportive, not supportive? What are their barriers? A lot of people don't come to treatment. Why? We want to know why aren't they coming? Is it distance? we all know that people are traveling not just a half an hour, but 2, 3, 4 hours for treatment. And if they're, if they can't find a ride, that's a big barrier. So what can we do to help some of those barriers? Who are their support systems? How are they getting the help that they need? Insurance is a big one. Are they Medicare, commercial insurance, Medicaid? Medicaid is a little iffy nowadays. Do they have the managed care insurance through Medicare? Those are even getting difficult. We found out some Medicare, like Aetna, is a perfect example. They used to provide 24 round-trip rides for patients. We heard a rumor that effective January 1st, they're going to do away with all the rides for their patients. So what does that do? That's going to provide another barrier. And so how do we, as social workers, help bridge that barrier? And feel free to jump in anytime, Barb. I feel like I'm monopolizing here. Do they have problems getting their medications? Some of the medications are $42,000 a piece, and that's for the oral drug. That doesn't include the chemo. My husband happens to have head and neck cancer, and he is getting Keytruda. His Keytruda treatments are $44,000 per treatment. Luckily, we're poor enough to fall within the criteria of getting some financial assistance for the medications. So medications are a big thing. If they can't afford their medications, they're not going to take it. And so we work with trying to help bridge the gap for some medications. Eliquis is a big one for some cancer patients. Employment status. We just like to know, are you employed? Are you working during your treatment? Are you unemployed? A lot of people are employed full-time but can't work during their treatment. So what do we do then? So we try to problem solve with them. And we'll get into that real quickly in a minute. Are they able to meet their financial needs? Are they independent in their ADLs? Do they use a cane, walker, wheelchair? Sometimes that's important because not every place is handicap accessible. So we want to make sure that they have what they need. The biggest question I love to ask, because not everybody is forthcoming, but at the very bottom it says, what do I need to know to take better care of you? And that statement to me, it's an open-ended question. Some people may say, I don't have any needs. But then there are others that says, you know what, I have a 5-year-old at home. I have grandkids. I don't know how to talk to them. I don't know what to say. I'm really struggling emotionally, and I need help. Well, luckily, we have some services that are able to, that we're able to refer them to. And one of those services that we have is we do have support groups. And I was going to bring a list of all our support groups, and I forgot them. But Illinois has a support group the third Monday of the month. It's for patients and their caregivers. What we do is it's for all cancers. It doesn't matter if you have breast cancer, colon cancer, if you have brain tumors. What we do is we have an educational component at the beginning where we have speakers come in. And then after about 40 minutes, we break up. The caregivers go with me. The patients go with our nurse practitioner. So, because I don't know about you, but a lot of caregivers don't necessarily feel comfortable talking about their loved one in front of them. And a lot of patients don't feel comfortable talking about the frustrations of, well, the caregiver's pushing me to do this, and she's pushing me to try this, and she's making me eat, and I don't feel like eating. So we separate. So I take the caregivers and she takes the patients, and it's worked out really well. So that they can, it's kind of a safe haven for both entities. And so we meet together, have our educational component, and then we split up. And then we,
I gotta get this.
oh,
You got
it's
a magic
not.
touch.
Here we go.
Clicking.
No, it's not a touch screen.
Oh.
You have to
Yeah.
use the mouse.
Ah, there we
Oh,
go.
the mouse.
The mouse, there we go.
The handy dandy
Thank you.
mouse.
I got it before.
Yes,
you.
we got it.
Wonderful.
We broke it.
Just say
Okay.
next slide and I'll advance.
Oh,
Okay.
okay.
Sure.
Well, next slide.
Thank you.
This is why you always bring an extra copy. We also refer to our psychology department for the psychosocial. They offer for the cancer patients 8 free sessions. Where they can talk with them about how they're coping, with their diagnosis. We have the support groups. We also have the cancer community support group, which is they just moved, so they're in
They're,
Westport now, I think?
Maryland, yeah, Maryland Heights. So it's a pretty good central location. And they do so many wellness type of groups, as well as diagnosis-related coping strategies. They do individual as well as group counseling. So it's nice because the patients have options. I often find I come up with a packet for people when they're looking for what support is out there, and I'll just kind of get to know them, where they live. If they're looking for in-person or telehealth type of counseling, and usually I'll have about 4 or 5 options, which is great. And they're, free. And I think, as we know with social media, that's been quite helpful for a lot of our patients, because Facebook will have a lot of good support groups as well. So we try to make sure we give them those sites and that information that's easy for them to access.
And a lot of our patients prefer the Zoom meetings also, because they don't have to travel, and it's easier for them, just to get on a computer, and they don't have to be quite as talkative if they don't want to be. So we found that the cancer community, the support community, has been really good, because they do a lot of Zoom and in-person meetings.
Stress management, that's something that we do, I think, in the moment with our patients. I know where I work, my office is in a very convenient location. There's the waiting area, the doctor's offices are right behind me, and I may have someone they're just waiting to get called by their doctor, or they just got their scan, and they're waiting to talk to their doctor about the results, and they may come in my office. We just do some good deep breathing, reassuring self-talk, and a lot of times just helping them, cope in the moment. Family members also come in sometimes and talk to us social workers. They may not have that other person to talk to, and they just want to vent, and we're here for them for that too. So advanced directives, like Julie mentioned, I think that's something that a lot of the nurses look at as well on the chart. They'll see, do they have one or do they not? If they don't, we have paperwork for them to complete that it's, Barnes Jewish WashU paperwork, and we explain what do those terms mean, help them in completing the forms, and then, have them added to their chart. And then we've got coping with return of cancer. This, I think, happens quite a bit. So we see a lot of new treatments that are effective in helping people. They, kind of go on about and return to their daily lives, and then they get a scan that leads them back to treatment. So we kind of help with that frustration or that fear that comes with that.
Food outreach is a big one. A lot of food insecurities now because the cost of groceries have gone up and the cost of everybody's Social Security and things and income has gone down. So we do reach out with the food outreach in St. Louis. They have a food pantry, and then they also will provide meals for patients that are currently undergoing treatment. And then they have kind of, like a food bank, a food pantry that they allow patients to go to. It's based out of St. Louis, but they also have an office in Illinois, which really helps for the Illinois. Next slide.
Next slide, please. Thank you. Yeah, this is a big one that I think it can be a really big barrier for treatment is the lodging. People drive from very far away to come to Siteman, so we try to help them with lodging. Some people may have a 7 a.m. appointment, and then they have scans, their doctor appointment, and then treatment, so they want to come the night before, get a good night's sleep, and then be kind of fresh. So the Hope Lodge is a wonderful resource that is a free stay for a patient. They also need a caregiver with them to stay. So we provide the referrals for that. And Haven House they moved this year, so they're now located a little further east of Hope Lodge. So it's kind of in the Midtown area, but they are a wonderful place. The social worker does referral to stay there.
And unfortunately, they're like $50 a night, where Hope Lodge is free, but at Hope Lodge, you have to have a caregiver. Haven House, you do not.
Yeah, we also we look at the Barnes Lodge, and then really a lot of the local hotels, because some people I know, if they're coming to the county for treatment, they don't want to have to stay in the city and drive. So, we try to connect them with reasonable hotels in the area. And then transportation, another big one, like Julie mentioned. We first look at their insurance, like what does their insurance cover it, and then help sometimes make those calls that can be time consuming to get those rides set up. American Cancer Society Road to Recovery is volunteer led, so those are volunteer drivers that will pick people up at their homes, take them to their appointments, and then take them home. The person, the patient does have to be ambulatory, but if they use a walker or cane, and can, manage that, they can be eligible. And then Peregrine Society is available for people that live in St. Louis City or county. They provide transportation through Yellow Cab or St. Louis Cab for up to about $600 per year. So that is a matter of, we get the patients, a referral to them, and then the staff there set up the cab service for the patient. Okay, next slide, please. Okay. So on to more of the financial needs. This is why one whole slide is for this. It's in this world we live in now. Finances are tight. So we do use the Elevate team. They assist people with Medicaid and Social Security applications. That is a free service for our patients. And I'll let you speak on this part.
Which one, the
The
elevator?
short-term.
The short.
Yep.
Yeah, we do discuss short-term and long-term disability with the patients. A lot of times, short-term disability, they may have it through their job. Other times they don't. So then we just try to we try to work with companies that may help them. Like LSUP is a corporation in Illinois that's nationwide. They can help with disability if the patient's going to be out more than 12 months, and if they're under the age of 62, we'll help them apply for disability if it's going to be more than 12 months that they're disabled. Unfortunately, if they don't have a short-term policy through their work, it's really hard to find a short-term disability. So we have limited funds available that sometimes we may be able to help them with an electric bill, with their rent. We unfortunately did not get the grant this year from the Cancer Society to provide gas cards for patients. So that has been one of our struggles, because some people can get to treatment if they can afford it. but they can't afford the gas. So, so we're struggling in some ways too, to try to find disability for some patients. And we do help them with public aid assistance. We do refer them to like the Patient Advocate Now foundations. Some of and we have a resources on the last page, which is coming up next. We do help them apply for the BJC and the Washington University financial assistance programs, because sometimes if you're on insurance, they may only cover 80%, 70%, 60%, and the patient can't afford their $44,000 treatment. So we do make referrals, and it's based on a sliding scale fee for the financial assistance. The Patient Care Fund is the limited funds that we do have available to help them. And then we also help with prescription drug referrals. We refer them to our patient authorization team. They design that team from the social workers who we were inundated every year with reapplications of medications. So they WashU developed a brand new prior authorization team that strictly covers the injectable medications, the oral medications. So if they're on a medication every month, they can get them covered for a year as long as they meet the financial criteria. And that has been a lifesaver for us because it allows us to focus more on their psychosocial needs and the issues that they may have. Last slide. These are just resources available that we do make a lot of referrals to triage cancer and careers. Those are the two big ones for patients that are working. That if they triage cancer is good for if they're going to have a disability and they need accommodations. They are excellent for telling them this is the accommodation you are going to need when you return back to work. Make sure you talk to your human resource department about this or about that. And the same thing with cancer and careers. The Cancer Society, the Cancer Support Community, the Cancer Institute, that's always the government, it's a good one. However, they're currently closed due to the federal shutdown. So their website even says, we are closed. So the information is not up to date. And then the Patient Access Network Foundation, we use them a lot for grants for some medications that we may need. And if anybody, you guys have a copy of our slides, so if anybody wants any of this information, you could probably get them, a copy. But I'm sorry we went over time, but we just feel that it's very passionate to us, and we want to make sure that our patients get taken care of, because there are a lot of people that do fall through the cracks, especially the middle class income, because they make too much money to apply for Medicaid, and they're not rich enough to be able to afford every single treatment that they need. So that's why we are here to, try to help anybody that comes through our desk or through our office, and we all have open door policies. So if our door is open and we're in there, we love to have the patients come in and to help them as much as we can. Does anybody have any questions? And I'm sorry we went over. Thank you.
Well, thank you very much. Clearly, what they do is invaluable, incredibly helpful. So next is Maya Patel. We have a registered dietitian who will speak on nutritional support, which is very, very critical in these patients all around their treatment journey.
Hi, everyone. I'm Maya. I'm one of the dietitians over at Siteman Cancer Center. I am one of 4 dietitians within the downtown Siteman location that works with our patients and helps manage their nutrition and diet during treatment. We also have Siteman satellites around the St. Louis area and also located in Illinois, where we also have dietitians that help with our patients and managing their nutrition during treatment. Oh. Okay, maybe it'll stick. Okay, so as a dietitian, we monitor our patients through assessments. We get referrals from our doctors, nurses, social workers, and even our inpatient dietitians that work within the main campus. Dietitians are super helpful in terms of assessing where the patients have nutrition-related risks, whether it's tumor-induced, treatment-related, or something they've been dealing with for a while prior to even being diagnosed with their cancers. So we basically get referrals from the team and meet with our patients the day of or at their next appointment or even over the phone at times to discuss what issues in particular they're having, whether it's poor intake, appetite changes, any symptoms that they're having, whether it's GI related or just like mental symptoms they're having, their medical lifestyle factors that might be impacting their nutrition and their nutritional status during treatment or may cause an impact to their nutritional status during treatment. And we also help them connect with our social workers, refer them over to speech language pathologists, and also just help provide handouts and recipes and ideas to kind of help them maximize their intake during treatment. So like I said, weight loss is one of the most common side effects that we experience with our cancer patients, whether it's weight loss prior to treatment or after treatment has begun. Most of the times it's appetite loss because a lot of the chemos can have that as a side effect, as well as where the tumor is located can also play a role. And if they're having any other symptoms like nausea, abdominal bloating, gas, any diarrhea or constipation, edema, ascites, which can also reduce their appetite, and then chewing and swallowing difficulties that, again, can be present due to the tumor location or also just be induced with chemotherapy or radiation. And a lot of our patients also experience some taste changes, which does not help if they're having some appetite issues because they're not going to want to eat food if they can't taste their food. So our patients also will experience cancer-related cachexia as well, and sometimes they're not able to meet their full needs with the diet that they're currently following, so we do help them manage their intake a little bit more to help them meet their calorie and their protein needs, as during treatment we recommend a high-calorie, high-protein diet in order for them to maintain their weight and also maintain their muscle mass as well. And sometimes if they're unable to meet those needs, because a lot of the times our patients are larger bodied or taller and they're not able to consume 3,000, 4,000 calories in a day to maintain their current weight, we'll need to start tube feedings or enteral nutrition. So like I said, we do recommend like a high calorie, high protein diet during treatment, and a lot of the times it's not an easy switch for our patients, especially people that are used to only eating one meal a day as their baseline or are more of like snackers and don't really eat meals at all. So really encouraging them to consume more calories, whether it's adding smaller, more frequent meals throughout the day or adding more calorically dense ingredients into their meals, such as butter, avocado, nut butters like peanut butter, almond butter, heavy cream, olive oil, things that are super calorie dense. They can sneak into something as simple as like soup if that's the only thing they're willing to eat, or their yogurt. We do have patients that are doing well nutritionally and just have diet-related questions, so we do encourage them to follow a relatively healthy diet that's full of whole grains, healthy fats, lean proteins, fruits and vegetables, and also encourage them to kind of reduce their intake of carcinogenic foods like charred meats, red meats, and also kind of help them moderate their sugar intake as well, especially if they do have a history of type 2 diabetes or they are on dexamethasone during treatment, which can impact their blood sugar levels as well and lead to the development of diabetes over time. We also want them to stay hydrated. A lot of our patients experience side effects like dry mouth, constipation, and just like skin dryness. So we really do try to get them to drink as much fluid as possible. We recommend about 64 ounces. If they're having any other symptoms that might be dehydrating them further, we try to get them to drink more, whether it's through water, juices, milk, or electrolyte beverages. We also discuss food safety with our patients. A lot of the times our patients aren't aware that eating raw or undercooked foods, like having a steak cooked medium rare, can put them at risk, or having food at a buffet can put them at risk of developing foodborne illnesses. So we always encourage them to wash their hands, make sure that their foods are cooked well, or at least medium if they're doing a steak, and make sure that they're checking temperatures on any food that might induce any foodborne illnesses, and then trying to get them to not consume as many raw foods like sushi or raw eggs or raw milk or anything like that. One of the biggest things that we do at Siteman Cancer Center that really does benefit our patients a lot is providing oral nutrition supplements such as Ensure or Boost. Siteman does have a program called the Ensure program, in which we provide our patients with free Ensure throughout their treatment. So if we do an assessment and find that they would really benefit from getting additional calories and protein from supplements, we do provide them with Ensure. We give up to 6 cases, each case containing 24 cartons of Ensure to our patients every 3 months. If they are not tolerating Ensure, or if they need more supplements than just the 6 cases that we give every 3 months, we do have the Peregrine Society that we often place referrals for our patients there. They provide Boost for our patients for free as well, and they do Boost Plus, regular Boost, and Boost Glucose Control, which is especially helpful for our patients within St. Louis that are diabetic and can't do the Ensure Pluses. So yeah, like I mentioned, we have the Ensure program and the Peregrine Society. The Ensure program is coming to an end at the end of this year, which has been a bit of conflict for our patients, but we are working pretty hard to come up with another method of supplementation for our patients. We just partnered with UHSP with their public health school to try to find a grant to help with funding and keep the Ensure program going for our more high-risk patients that are consuming up to 4 to 6 Ensures or more a day. And also getting our patients enrolled in the Peregrine Society if they just need a few bottles every single day, or as needed to kind of help them maintain their weight and lean body mass. We also encourage those calorically dense foods, and also discuss altered consistency diets, which we work a lot with our speech language pathologists to help develop good recipes and good meal ideas to kind of help make sure that even if our patients do need a pureed or mechanically altered diet, they are still able to meet their calorie and protein needs. And we also help them find smoothie and shake recipes and kind of set up like a meal program for them to make sure that they're able to not get sick of all the foods that they're eating. If they're only drinking Ensure, what can we do to make those Ensures taste different and not be the same thing every single day? And also give them a little bit more savory options, because not everyone can drink Ensure and ice cream and smoothies every single day and not get sick of it. So we try to make sure that we're teaching them how to bulk up their soups and bulk up like baby food, and try to make it easier for them to consume food that way. And then we also have a lot of patients that are older or just have a lot of fatigue during treatment. So we really try our best to encourage them to pick frozen meals or pre-prepared meals, and keep snacks at their bedside tables or in their living room on the by the couch, so they don't have to get up or work too hard to prepare those meals for themselves every single day. We also work with our social workers within Siteman to help them get referred over to food outreach, like was mentioned previously, as well as pink ribbon meals, mom's meals, Meals on Wheels, just trying to make it easy for them to obtain food, and also discuss grocery delivery with them to just, again, make it easier for them to have food and that not be a barrier during their treatment. A lot of our patients, especially our GI cancer patients, develop mouth sores during radiation or even during chemotherapy. So we work a lot with our nurses and doctors to kind of set up interventions for them. We'll recommend like magic mouthwash, baking soda rinses. For the mouth sore specifically, we work with our speech language pathologist to help identify swallowing difficulties and help them just figure out what consistency diet would work well for them and how to purchase foods and prepare meals that are going to be manageable for them with that altered consistency. We also help put in enteral nutrition orders, as well as recommending like G tubes versus GJ tubes, and the tube feed regimen that they would be placed on after those tubes are placed in patient. We also help manage taste changes, which again is a big barrier when we're trying to get them to eat well. If food isn't tasting good, bland, if it's metallic or just bitter tasting, we help a lot with managing that, whether it's through improving oral hygiene, doing those baking soda rinses, or encouraging them to sip on cranberry juice in between their meals to kind of help refresh their taste buds. Dry mouth is another big one that we experience, so we recommend mouth coat, the Biotine. Sour candy has been really helpful for a lot of our patients to help stimulate more saliva production. And then just making sure they know not to do too much alcohol or caffeinated drinks, and trying to help manage their hydration again with adequate fluid intake, or even adding like citrus to kind of help stimulate that saliva production again. More symptoms, we always go into our assessments asking if our patients are experiencing any nausea, vomiting, gas, bloating, constipation, diarrhea, or even just the consistency of their stool to identify if they might need pancreatic enzymes to kind of help absorb that those fat-soluble vitamins, and also not have that malabsorption. That's pretty common with some of our GI patients. We have a whole bunch of interventions that we discuss with our patients in terms of nausea. We partner and request samples from a lot of small companies. For example, we've been getting samples from the Gingin company to help with nausea management through their ginger chews and ginger lozenges, which a lot of our patients have benefited from. We recommend bland diets if they're experiencing nausea or diarrhea. We help a lot with the gas and bloating side effects, and just try to coach them diet-wise to make sure that their diet isn't contributing further to any of those symptoms that they're experiencing. And also work with our pharmacy team to kind of identify which dosage of pancreatic enzymes would be suitable for them, and also work with our social work team to kind of help cover the costs of some of those pancreatic enzymes, because they do get pretty pricey, as well as refer our patients over to Nestle if they are able to help with the cost of the pancreatic enzymes as well. And again, we do have a lot of patients that are unable to meet their nutrition needs through their oral intake, whether it's because of dysphagia, the cachexia, like I mentioned, causing their needs to be quite high to the point where they're unable to meet at their oral intake. If they have been diagnosed with malnutrition again and are unable to meet their needs through oral intake, we recommend enteral nutrition. A lot of our patients will undergo an esophagectomy or gastrectomy at some point, or have dysphagia caused by radiation treatment. So we do keep an eye on them and encourage enteral nutrition to be initiated if the patient is agreeable and we think it would be beneficial for them. In some cases, we do have patients that need TPN or PPN for a short amount of time. So we work a lot with our home health dietitians as well to help manage their TPN, and if they start to wean off of them, we help in managing that and make sure they're still able to meet their needs and maintain their weight while they're weaning off that TPN. And that's it. Thank you. Any questions for me at all? Thank you.
We can also do questions later. Thank you very much. All right, next up we have Anna Pruss, who will provide some very nice expert perspectives on nursing support and the role of nursing. Anna?
Hello, my name is Anna Pruss, and I'm oncology nurse coordinator. I work with Dr. Jin, and I also work with Dr. Andriatos, who's here today as well. I work with the doctors to manage about 200 patients and family members and act as their first point of contact for their doctor. A little bit about me. I've been a nurse for 8 years and have been in this current role for 4 years. So a little bit about what I do. Like I said, I serve as the first point of contact for both patients and any family members or friends with whom the patient authorizes me to speak. As my role suggests, I help coordinate with other departments on patients' behalf. I schedule scans and office visits with Dr. Jin, which are scheduled same day. I also reach out to other providers on the treatment team, such as Dr. Panny and Dr. Brandt and Dr. Kushner, who all spoke earlier today. I help arrange biopsies and endoscopies, both of which have their own departments, so it requires a bit of more communication between departments and patients. And all endoscopy and biopsy requests, the reason it takes a while, because it must be approved by radiology and GI respectively before either can be scheduled for a patient. Clinical trials, you've heard a lot about clinical trials today. Each clinical trial has its own clinical trial coordinator. So the clinical trial coordinator and I join forces to get appropriate screening, labs, scans, biopsies, etc., scheduled for the patient. Throughout the patient's experience on the clinical trial, the trial coordinator and I continue to collaborate to ensure that all study requirements are met. I also collaborate with palliative care. Palliative care is a service that focuses on symptom management while a patient is undergoing chemotherapy or a clinical trial. Most often, this involves pain management, but also includes appetite stimulation and even includes discussing how the patient is handling their diagnosis and treatment. I've found that at different institutions, there are different definitions of what palliative care means. At some institutions, it is synonymous with comfort care or hospice. So sometimes patients, I found, get scared when they hear the words palliative care. So every time I discuss palliative care, I make sure to underscore the fact that at Siteman, palliative care is for patients who are living with cancer, and that hospice is a separate service. Sometimes patients get admitted to the hospital, sometimes there are complications, but when a patient is admitted to the hospital, Dr. Jin and I are frequently in contact with the inpatient hospital team. Dr. Jin and I collaborate on patient care, and while the inpatient hospital team manages the patient's care while they're in the hospital, Dr. Jin and I are always aware of the inpatient team's recommendation and the patient's progress. The general flow of a treatment day for a patient, from a patient's perspective, always starts with a lab appointment. We need to have the most current labs for each patient so we can determine whether or not it's safe to give the patient chemotherapy that day. Next, the patient will have an appointment with their doctor, and the doctor will assess how well the patient is doing, how they're feeling. We'll go over patient's lab results and scan results if they have scans available, and we'll listen to the patient's heart and lungs. After the patient is finished with the doctor, assuming that they're okay to receive their cycle of chemotherapy, the patient will go over to the infusion center to receive their infusion. When we introduce a new chemotherapy, I go over the chemotherapy with the patient. I always tell the patients that the most important thing to remember is that if they develop a temperature of 100.4 degrees or higher, that they call me immediately if it's during business hours, or call the after-hours exchange immediately if it's on a night, weekend, or holiday. Those of you in the room that have met with me have probably heard me give this speech before. I also ask that patients get a digital thermometer that goes under their tongue and is easy to read to check their temperature at home. A phrase that we use commonly in the GI oncology world is the term chemotherapy cycle. It can be a confusing term, so I'll explain what it refers to. If patient's chemotherapy is every 2 weeks, for example, then your chemotherapy cycle will be 14 days long. If you receive chemotherapy every 3 weeks, then your chemotherapy cycle is always 21 days long. The day that you received your chemotherapy infusion is always day 1 of your cycle. It's important to know which day of your chemotherapy cycle is day 1, because oftentimes patients are prescribed dexamethasone. Maya touched on this briefly in her discussion. It's a steroid to take on certain days of your chemotherapy cycle. The dexamethasone helps to prevent nausea, and helps to prevent fluid retention in patients who receive docetaxel, one of the chemo drugs given in the acronym FLOT, which is a common chemotherapy given for esophageal cancer. Something that patients often worry about when anticipating receiving chemotherapy is nausea and vomiting. This is completely understandable, especially given how chemotherapy is portrayed in the movies and on TV. At Siteman, we help prevent nausea in several ways. We give anti-nausea medication through the port before the chemotherapy is infused. These anti-nausea medications work over a long period of time and often stay in the patient's system for about 2 to 3 days after infusion. We prescribe 2 oral anti-nausea medications that patients take home, prochlorperazine or compazine, and ondansetron or Zofran. These medications are available to the patient, and we encourage patients to take the medication even if they're feeling just a little bit nauseated. Some patients even take the compazine and Zofran around the clock to prevent nausea from coming on to begin with. Something that can be confusing, and it is worth mentioning, is that both compazine and Zofran can be in the patient's system at the same time. So I suggest that patients take one. Some patients prefer to start with Zofran, some patients prefer to start with compazine. Wait for 45 minutes, and if the patient's still feeling nauseated, to then take the other anti-nausea medication. You just have to keep track of when they take each medication, because the compazine can be taken every 6 hours and the Zofran can be taken every 8. I mentioned port earlier. I wanted to touch on what those are. Patients who start IV chemotherapy will need to have a port placed. A port is a circular, penny-sized rubber hub that is placed under the skin on the right side of the chest wall and has a long tube attached to it. The end of that tube goes into the superior vena cava, a large vein that takes blood back to the heart. When the patient gets chemo, a needle is inserted into that hub under the skin, and the medication goes into the catheter that is located in the superior vena cava. Then the heart pumps the chemotherapy throughout the body. Once the chemotherapy is finished infusing, the needle is removed from the hub of the port. There's nothing that sticks out of the chest, so patients can shower, swim, and take baths as they normally would. Additionally, the ports that are placed at BJC are called power ports, meaning that when the patient has a CT to check their progress, the chemotherapy port can be used to inject the IV contrast, so the patient doesn't require a second IV to be placed. These port placements are done outpatient. The patient is put under mild anesthesia, and they can go home afterwards, but they'll need a driver. The most important role that I have in my job is triaging patients who call with symptoms. If a patient has concerning symptoms, the patient starts with calling me. I ask a series of questions to get a better idea of the whole picture, and then depending on the symptoms and the severity, I will recommend next steps with Dr. Jin's help. I make sure that the patient is not experiencing emergent symptoms such as chest pain or shortness of breath or a fever. Sometimes, when appropriate, I will refer the patient to the cancer care clinic. The Cancer Care Clinic, I'm sure some of you have been there. It is a nurse practitioner-run clinic for cancer patients located in the lobby of the Center for Advanced Medicine, or the CAM, as we call it. It's kind of like an urgent care for cancer patients. It is a fantastic resource. Patients need to have appointments, which have to be made by us, the nurse coordinators, so unfortunately, it's not a walk-in clinic. We call it the CCC for short. So the CCC can do all diagnostics, including urgent CTs. However, the CCC is for stable patients only, and patients who are unstable will have to go to the emergency room. The CCC is open 24 hours a day, 7 days a week, including holidays. So patients who need an infusion, fluids, an injection, or chemo pump disconnect on a weekend or holiday will have those done at the Cancer Care Clinic. It's important for patients to know that evaluations done in the Cancer Care Clinic can take a few hours, and I always remind patients to bring some personal belongings to the Cancer Care Clinic in the event that the patient is admitted to the hospital from the Cancer Care Clinic. The nurse practitioners who do the evaluations are in contact with Dr. Jin and myself, so not only are we aware of what's happening with the patient, we also have input. And the last thing I wanted to bring up is the little bit about why I do the job that I do. I've had patients ask me before, how I can do this every day, because sometimes it can be sad. The reason is I get to meet patients at one of the most, if not the most challenging parts of their lives. And those of you who are here have let me into your lives, and some of you have even let me into your families. And in my opinion, to be able to help someone through that part of their life is an honor. So I want to thank you for letting me do my job. Thank you.
All right, so then I will introduce our next speaker, Dr. Amaris Tippey, and she's going to talk to us about Siteman Psychology Service and the great work that she does with our patients.
Good afternoon. Thanks for hanging out to hear me talk. I know it's been a long day, exciting. Each patient with cancer and their caregiver has a story, an experience, and while a lot of today has been regarding treatments and tests and logistics and resources and things like that, we want to also think about the people inside those stories, right? You. And the emotions that can come with facing cancer. When someone is diagnosed with cancer, it doesn't just affect the body. It comes in and touches every part of life to some degree. Your thoughts, relationships, sense of control. Feelings like fear, sadness, anxiety, or even anger are not signs of weakness. They're normal human reactions to a challenging situation for both patients and their loved ones, including caregivers. We call this cancer-related distress, and it's something nearly everyone goes through at some point when cancer has impacted your life. So here at Siteman, we have an oncology service that is absolutely free to every patient. We do have groups for cancer caregivers as well. We work hand in hand with the medical team to help you cope and find strength and even approach end of life if that is occurring. Our goal is to make sure that emotions are felt, seen, and validated in regard to your cancer care. Adjustment to cancer is just not a unitary single event, but rather a series of ongoing coping responses to multiple tasks associated with living with cancer. Those can be different for everyone, but you can see here that there are common periods of distress and significant challenges, and waves of distress are not uncommon. So what we typically see is that patients kind of have like a roller coaster of distress. So there's periods where maybe distress is lower, and then especially kind of transitioning to any one of these periods, like a new treatment, or even survivorship if your cancer is controlled, can bring on some of these emotional responses. Here you can see some of the psychological impacts of cancer on our patients and caregivers to some degree. Some of them are relevant, others not. But the National Cancer Institute describes distress as an extending along a continuum ranging from common normal feelings of vulnerability and sadness to problems that can be disabling, such as depression, anxiety, panic, social isolation, loneliness, and maybe even spiritual crisis. So while not everyone develops a clinical diagnosis like major depressive disorder, generalized anxiety disorder, or post-traumatic stress disorder, most patients are impacted on some level to some degree by cancer-related distress, at least intermittently. So what I'd like to do is just look a little bit closer at depression and anxiety. Depression is not only simply a feeling of sadness or tearfulness. It's a disorder with specific symptoms that can be diagnosed and treated. And for patients with gastric cancer, we anticipate about 3 out of every 10 patients to be diagnosed with major depressive disorder. That does not include patients who don't meet the criteria for depression but have underlying feelings similar but might not meet criteria. Numbers for men and women are about equal. And here we see some of the other symptoms of depression, because many times we'll hear, oh, they are sad, right, in general, but there are cognitive, behavioral, and somatic symptoms of depression. So you can see here kind of the cognitive criteria for depression: trouble focusing, difficulty making decisions, memory problems, sometimes suicidal ideation or thoughts about wanting to end one's own life. And while it might seem ironic when many patients are undergoing treatment for cancer, sometimes they simultaneously have thoughts about wanting to end their life. And that's not uncommon, and it can be very confusing for patients. Behavioral symptoms: loss of motivation to do daily activities, loss of interest, withdrawal or isolation, frequent crying, anger. This is one that's not necessarily known in kind of the lay population that doesn't do this work on the daily, but anger is often a symptom of depression in women and especially in men, so increased irritability and anger. Finally, there's somatic symptoms you can see there: fatigue, appetite loss, things that kind of affect your body. Sexual problems. Sexual problems are not often talked about by providers, or not often brought up by patients, right? But it's a common concern that often leads to distress in cancer. So you'll say, well, my treatment might cause some of those, right? Like trouble focusing, or memory or fatigue, appetite loss. So we take that into consideration when we're talking with our patients. A next big player is anxiety. Anxiety occurs in varying degrees in patients with cancer, including gastric cancer. Investigators have found that 44% of patients with cancer reported some anxiety, and around a quarter of patients reported significant anxiety. Anxiety, in this sense, is often exacerbated or made worse by uncertainty and loss of control, and may also be secondary to other aspects of your medical condition. So for example, uncontrolled pain, nausea, medicine side effects. There's a number of reasons that it can come up. All patients, all providers, me, experience normal worry, okay? But I'd like to contrast normal worry with some serious symptoms of anxiety that may occur. So normal worry kind of comes and goes, may have some difficulty concentrating, but you're able to kind of turn off those thoughts, okay? You may have some kind of sense of crying spells or fear, but if we look at the more serious symptoms of anxiety, that worry seems constant. You're unable to concentrate, you're not able to turn off your thoughts, you might have difficulty sleeping, fear and apprehension are just kind of always present. Can have many physical side effects, so panic attacks, racing heart, dry mouth, restlessness, shaky hands, fidgety, feeling keyed up, just not able to sit still. And you don't really have the ability to reduce those feelings very easily. This side of the continuum, right, like that we're looking at, is fairly common in cancer in general. This side is when we get more serious. And I don't know if you guys are provided these slides, but you can have that to look over too. So why is psycho-oncology important to oncology patients? It's a growing area of oncology over the past 30, 40 years that focuses on the psychological, social, and emotional impact of cancer on patients and caregivers. We address psychological issues affecting patient and caregiver quality of life. We work to empower patients to take a positive and active role in their cancer care. We help with communication, and we try to help patients and families adjust to a difficult disease and a difficult disease process. Psychologists often practice in individual and group settings. An extensive body of literature supports efficacy of psychosocial interventions for patients with cancer. You can see some of them here. Psychological and social interventions have generally been identified as non-pharmacological, right? So if you come to our service, we're not going to immediately try to give you medicine to take care of the situation. We're going to sit, listen, provide support, kind of get an idea of what your experience has been like, and then provide recommendations we can find helpful. We often pull from a number of these interventions instead of sit down and do an entire protocol, kind of manualized situation. We don't do that unless it's really needed. So here's a list of some of the evidence-based strategies. One of the ones that I want to highlight is problem-solving interventions versus emotion-focused coping strategies. I think this is the one that I see most significantly. Probably for almost all of you, you're probably pretty decent problem solvers. If I put a problem in front of you, you can find some kind of solution. But if there's a problem that doesn't have an accessible solution, like feelings of emotion and all of that, we need these emotion-focused coping strategies. And including myself, probably most of us in this room are lower on that continuum, and that's where we can bolster you up to help feel those feelings, learn how to sit with them, and allow you to navigate your life forward. We know therapy groups have similar effectiveness in many patients and individual therapy, and also have the extra component of normalization, validation, and reducing feelings of isolation and loneliness. That may, if there are patients with us, be one of the reasons why you came today, maybe to be with other people that can understand your experience somewhat. Our current groups at Siteman Psychological Services include a newly diagnosed group, which is diagnosed within the 6 months, metastatic cancer group. I run a young adult metastatic cancer group for people under the age of 45. We have a survivorship group that are people who are in remission or on long-term maintenance therapies. And we have a group for caregivers, and I also run a mindfulness and stress management drop-in class. I can see some people shudder at the thought of groups, but what I will say is if I can convince a patient to join a group, it is so powerful and they're so thankful. So if you're kind of on the fence, interested, join us once, see what you think. So we are lucky that Siteman values this aspect of our patient care. We have 7 licensed clinical psychologists and often 1 to 5 trainees, including postdoctoral fellows, interns, and residents, and doctoral students. We see patients from diagnosis through survivorship. Unfortunately, we're unable to see patients for grief therapy, but we do have great referrals for that. We see individuals with cancer and caregivers. Currently, many of our caregivers are actually seen through our cancer group because we have to prioritize the influx of patients that we get. We do have individual referrals for caregivers as well. All of these services are free, but it is brief, so it's limited to 10 sessions, and it's not on the slide, but it's all telehealth. So it's either on the phone or Zoom per patient preference. And it's all cancer related. So if there's not a cancer related portion to your distress or concern that you're bringing forward, we would refer that out. And while I briefly discussed a list of interventions and strategies, when psychologists choose an intervention, it's never just about treating symptoms. It's about connecting with what truly matters to the person in front of us and using some of those evidence-based strategies in reducing symptoms, improving their quality of life. So I'm hoping now we can hear from a few patients going forward. So thank you for your time. If you have questions, happy to answer them later. And for a referral, the oncologist can place a referral, or you can call and self-refer.
Thank you, Dr. Tippey. And now I'd like to introduce our first patient perspective, Sidney Raskind. No Stomach for Cancer representative here, so he would like to talk about his experience gastric cancer.
Hey, that's me. It's a very big me. Hello, everybody. My name is Sidney Raskind, aka Sidney Raz, all over the internet. Like that slide says that I made in the back while everyone else was showcasing that they already had prepared slides. I do have about 8 million followers across the internet. I got well known for posting about life hacks, tips and tricks, and my tagline is things I wish I knew before I was in my 30s. Became popular around the same time everyone else did, or with COVID, everyone being at home, that kind of thing. So that's kind of how I got my following. Starting with that, it has lasted for about 4 years full time, which is my dream come true. And then in March of 2025, I was diagnosed with stomach cancer, stage T1A. So just want to say thank you for inviting me to this. Thank you for being in the room. It feels very nice to not be the only guy with cancer in the room, to just be around people that, you know, I can look at and go, no, you have chemo. I'm not. I just had my stomach removed. I'm not a big deal. No, thank you. Because when I say I have cancer, everybody wants to know who, what, when, where, why, you know. How did you find out? Why did you take your stomach out? Can you burp? Things like that, right? So again, just thank you to John. Thank you to everyone in this room. But let's go to my story. Kind of going over it a little bit. Basically, in March of 2025, I got a upper endoscopy because there was a chance that I had stomach cancer, hereditary diffused, because I found out that I had a gene deletion, ctNNA1, which is the cooler version of CDH1 in my opinion, because I'm nothing if not a hipster in all things, even cancer. So I got that phone call that I had the gene deletion in 2024, October 2024, and then I wait a little bit, decided to get the upper endoscopy done, and then of course I come out of the upper endoscopy at City of Hope in Duarte, very close to me, in Los Angeles, and everything looks good, right? Oh man, your stomach looks great, bud. Yeah, don't worry about it. Then about a week later, sorry to tell you, you have stomach cancer. What do you mean, right? What does that even feel like? The presenter right before me talked about anxiety, depression, bouts of fear, uncontrollable sadness. I had it all, right? And meanwhile, I have a toddler in the other room, just being a toddler. Very difficult for anyone who doesn't have a toddler. So then we go in, we find the 1.7 millimeter cancer in my stomach, and we have a choice. Either you take out your stomach or you're surveilled. So my wife and I decided to take out the stomach. And I can't tell you how sort of relieving it was for the doctor when Dr. Yang-Hee Wu walked into the room after reading a chart of a 36-year-old seemingly healthy male, no underlying conditions, maybe could lose a few pounds. But that was her words, by the way, not mine. And how relieving it must have been for her. For me, after getting this diagnosis and having it explained to me, and looking at her and going, no, you don't need to convince me to get the stomach out. It's good, take it out. Because I didn't want cancer. Everything else doesn't matter, right? Oh, well, you're gonna have to change your diet. Oh, well, all of these things. But for me, the cancer issue was the big thing, because I had already lost my mom to cancer, lobular breast cancer, which, ironically enough, is caused by ctNNA1. But nobody knew that at the time. So I wasn't gonna leave my wife, I wasn't gonna leave my daughter, I wasn't gonna leave anybody behind, especially at 36. I mean, look at me, I'm gorgeous. So basically, That was a big swing. I appreciate that. Thank you. Basically, we didn't really have a choice. It was take out the stomach, right? So then I posted about it on the internet because I got a lot of followers. And then I found this incredible community. And then John calls me and goes, whoa, 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 whoa. Maybe you don't need to take it out like tomorrow. You can wait a sec. And I went, nah, come on. Cancer bad, out good. But then I talked to other doctors in the community. I talked to other people in the community, Dr. Jeremy Davis, and got more testing, and endoscopic ultrasound came back positively, and I decided to wait a few months and just grieve the loss of my stomach while I had it in the best way I can by eating everything, gaining more weight, because obviously I'm going to do that, and going to Vegas. That was probably the best decision I've ever had. It was my first time and last time with my stomach in Vegas. And I will be going back without a stomach. And I just had fun. I just had a fun 3 months. I vlogged it, I posted about it, raised money, and tried to understand this new existence that I'm living in now. And then July 3rd of this year, I got to celebrate Independence Day from the British and cancer. So that's when I had my total gastrectomy. And it has been a steep learning curve. It has been not as difficult as it could have been. I think I was already sort of becoming more connected to my religion and Judaism before this. And then once I found out that you can get a genetic test done that connects an entire generation and generations to come and generations before, I thought, okay, I'm good. I'll go to temple more, you know, that kind of thing. But since July 3rd, it's been difficult, but also worth it, because now I don't have stomach cancer. And I've been really happy to meet all these people, and it's been incredible. A big part of that story is the genetic testing, right? Why did I get that genetic testing? Well, the reason for that genetic testing was because in August of 2024, I lost my second daughter to holoprosencephaly, which is a genetic or a birthing defect, which basically my second daughter wasn't growing a brain. So we lost the pregnancy, and we wanted to find out why. So we sent out some of her DNA after she was delivered, after holding her, after going through that process. And when we sent out some of her DNA, she came back with the marker. She came back with the ctDNA explanation for my mother passing away and for me almost passing away. So Delphina Joe is the reason why I'm here. And she's the reason why now I can tell my living daughter, my cousins, my aunts, everybody, to go get genetic tested. This is ctDNA1. Hey, if you have it, you might have to get your stomach out, but at least you don't have cancer. So I always get to say something where it's like, well, if you really want to be depressed, let me tell you how I found out. That's depressing. And since it's so depressing, let's go into questions that I get asked from the internet about not having a stomach, because they're way funnier than the story I just told you. How did you recover so quickly? My best friend and basically my sister-in-law, Lindsay, asked me. Well, I had to tell her this, and since this is being recorded, I will say it again, because you helped me. And my friends and family matter a lot. So thank you, Lindsay. Thank you. Can you eat any foods, or are there any foods you cannot eat? I get very lucky to answer this question, right? Because, nah, dude, I'm eating everything. Maybe a little bit slower, maybe a little bit less when I take the big bite and have to think about it all the time. That's been pretty annoying over the last 3 months. Because before I had my stomach, oh boy, I was gross. What's been the most challenging part about this change? My blood sugar levels, I would have to say. I recently started taking ADHD medication. I don't know if you could tell. But my blood sugar spikes have been crazy. My weight loss recently has kind of not been alarming, but it's like, oh, I look like I was 21 again. That's not good. Or is it? But the blood sugar thing has been hard, right? So constantly having to snack, constantly having to like make sure that I'm not angry for no reason, right? Because there's no stomach stopping me from getting to the angry for no reason part of eating. So I think that's been the most challenging thing for me. Do you always feel hungry? No, because I never feel satisfied. So it's like this weird thing where I'm basically just a luggage carousel for food, where I just eat, wait 30 minutes, it goes down, wait 30 minutes, maybe have something else, and then it just keeps going. So if I never feel satisfied, I never feel hungry. And if anyone has seen The Curse of the Black Pearl, when Captain Jack talks about this, or not Captain Jack, Captain Barbossa, the bad guy, it's basically like that, except not in a terrible, ghoulish way. So no, I don't always feel hunger, but I also never feel satisfied. It's really, really weird. Does food taste different? This is something that I thought would happen. No, food does not taste different. It still rips. It's awesome. Probably even a little bit better now because I'm so grateful that I can still eat it. My food intolerance isn't there, so it's been amazing. Who or what has been your best resource? Shout out John. Right? Shout out Hope for Stomach Cancer. Shout out No Stomach for Cancer. Shout out so many incredible people. All of you in this room. Incredible resource. And of course, since this is being recorded, my wife, obviously. Only my wife. Because without her, I would not be here. I cannot stress that enough. She has saved me so many times. Was there a point when you thought you weren't going to make it? Absolutely. There was a point in those first few weeks where I didn't know what kind of cancer I had, how much, where it spreads. And I thought, that's not good. I'm going to be as coherent as possible through this process, but until we know that I'm not going to die, yeah, I thought I was going to die. But since I had been through it so many times, one of the biggest things that was pulling me through the grief process and knowing that I had to just kind of like keep my head on was knowing that I didn't want to leave my wife and daughter, was knowing that I had access to therapy. I had 100 milligrams of Zoloft already pumping through me because PTSD, dog. So I was okay, but yes, I was scared. But then I got more information and I wasn't as scared. The mental health piece must be a huge part of this recovery. What steps did you take? I encourage anyone who has not been to therapy to go to therapy. It's really helpful, especially when you think everything's ending and you can't stop crying like we just heard about. And for so many other reasons, therapy has been so helpful. My wife and I are in collectively 3 therapy sessions a week. Personal, couple, me, her solo, us together. I would say that I think I gain more benefits from the couples therapy, but that's just me. So go to therapy, y'all. Even if you don't have cancer, go to therapy. Have you eaten at any restaurants yet? Yeah, and it was scary. One of the things that I was really not looking forward to was being stared at while I was eating. Everyone in my circle knows me. Everyone in my circle knows how hard it is to exist already. So to have something like, hey, that guy's got no stomach. This is going to be cool, right? Terrifying. What's also really, really, really inconvenient and rude of a lot of people in restaurants is they still have stomachs. Not cool, guys. Not cool. I would appreciate it if you did not shove that in my face all the time. But it isn't. Everyone's there just eating at a restaurant. I can order the same food. I don't have to be scared. Nobody thinks about it that much. If anything, my close friends and family, we all just enjoy the experience of me being there a little bit more now. And yeah, I eat slower and I'll eat some of it later. But yeah, restaurants were scary, but I go to them a lot. And I feel kind of vindicated too, to be like, yeah, I'll get that spicy thing. Oh, cake? Gimme. Not too fast, but gimme. Is there anything you can't eat anymore? I already answered that. People really like to ask this question. This is the big one. It's like, what can you not eat? How are you managing getting enough calories? This is something that I'm still learning. Since my surgery, my total gastrectomy was only in July, I'm kind of learning how to eat again. My body is learning how to balance everything out, right? It's difficult. But my mother-in-law, when my father-in-law was passing away from cancer, gave him Benecalorie. So much to the chagrin of me having to say that my mother-in-law is right. For any of you in here with son-in-laws that also have that problem, I apologize. We're doing our best. I have Benecalorie now in my bag, right? Just in case I need it. I still eat the same amount of meals. I still eat generally the same amount of food my wife does, the same amount that I was when I was a stomach person. Now that I'm a stomachless person, I feel like I am still eating, but I'm still losing weight. So I'm still balancing all of that out. Is it a multivitamin? Is it a different type of high-calorie food? We were really, really, really diligent at the beginning of getting enough calories. But as Dr. Yang Hee Woo mentioned, you breathe and you lose 1,500 calories. That's all day, right? So if I have to get 2,100 or maybe even 3,000, that's kind of difficult because I wake up and I need to start eating butter. Like what do you do? The answer is yes, it's butter. Just add butter to everything. Mayonnaise, it's pretty good too. This is a question that I would actually like to talk about with people after this session today is done. But the process is similar, but a partial stomach removal is more connected to a gastric sleeve, right? Gastric bypass. So since there's food somewhere to catch, and that bowl is still there to muddle things up, I do obviously connect with this as, yes, stomach cancer, marker for your husband, partial stomach removal. But in my experience, some people that I've talked to that have gotten the partial stomach removal have just done the total gastrectomy later, right? So to me, I'm like, yeah, it's pretty much the same, except I don't have a stomach. You will still have a stomach. So I don't know. It's like a toss-up, right? It's like, I really hope my answer for the internet was, I'm so sorry about your husband. That's terrible. Obviously, this is very similar to mine, but definitely look up the symptoms and care for someone with a gastric sleeve. That's usually that's what I would tell people. I always have to preface all my videos with, hey, I'm just a guy. I'm not a doctor. Please don't listen to me as much as you could to a real doctor. This is one that I mentioned earlier. Has your perspective on life changed at all? I'm a little less annoyed with my toddler. I'm a little less annoyed when she screams at me because I just want to brush her teeth. Or if my wife and I get into an argument, I'm a little bit more aware of the fact that I could have not been here if we had waited 3 years. Obviously, my connection to my spirituality helps a lot with that. My perception of what matters kind of changed a little bit. But I think that's evening out, so I think I'm getting back to my old grumpy self, so that's good. Bioreflux is something that people ask me about a lot. I was scared of bioreflux so much in the hospital that I did not lay down straight for 7 days. I couldn't do it. I was scared. I don't recommend it. It was awful. My back still hurts. But the way that I mitigated this was just by having a wedge pillow. Wedge pillows are fantastic. They're very cheap, they're very comfortable. Couldn't cuddle my wife as much, but not having bile reflux was totally worth it. Now I'm okay, about 3 months out. I don't really have that issue anymore. Actually, yesterday in the hotel room was the first time where I ever got to a bed and laid on my back without even thinking about it. And I just stared at the ceiling and I thought, nothing. Whoa. And I never thought I'd be able to do that again. So bioreflux is a big one, but it's not as bad as I thought. Has my recovery been better or worse than I expected? Much better. Much better. And I chalk this up to being young and healthy. 36, all of my other organs working. Didn't ever really have the best relationship with my stomach before. Had really bad heartburn, not because of cancer, but because of a hernia on my esophagus? Question mark, doctors? Yeah? That sounds right? That one guy's nodding? Okay, cool. So they took that out. That was pretty cool while they were in there. But yeah, so now I just feel like my intestines have been doing a lot of the work anyway. So now I think my body overall is just very supportive, more so than I think a lot of people have it. How do you stay hydrated? By drinking water. It's pretty cool. Drinking water is something that I didn't think I would be able to do. I thought I would lose it completely. So I'm kind of thanking God every day that I can still drink water and enjoy water. Maybe one day I'll have to go into liquid IV or something, but right now I just drink slower. I kind of like it, actually, because now I know the true volume of how much space I have. 2 big gulps instead of 1.5 minutes of gulping. So yeah, I still stay hydrated the same way. It's just very similar to eating. You just take it slow. This is a weird one because no, I don't get food stuck in my esophagus, but this is how I feel full. Because food, if it gets stuck in your esophagus, you are in a way worse shape than you think. You're gonna choke to death. So no, I don't feel this. I chew a lot. I chew so much that I think I'm getting strained. The next one coming up is one that I get a lot. Yes. And it's bad. I don't recommend it. Just to go back to this one really quick. I'm so sorry to my wife. We got an air purifier just sitting in our room, always on, always plugged in, just in case. So it's a very big deal. And it was one of the things that I did not expect. How are you navigating chewing and swallowing? I do it a lot. It's probably one of the biggest mental hurdles I face every single time I take a bite. Dr. Davis was the first one to tell me about that, but I didn't expect it to actually make me sad every time. I didn't expect to struggle to not swallow as much as I want to, right? So now I'm just still getting used to it. But yeah, chewing and swallowing, it's just a lot more work. What do I miss the most about pre-op days? Drinking water for 1.5 minutes. I made videos, I vlogged, and one of the things that I knew I wasn't gonna ever be able to do again was really just go to town on some water. Just demolish a whole bottle, right? And feel that encompassing relief of coolness in your stomach. That's the thing I miss the most. Yeah, that's the thing I miss the most. But again, very lucky that I still get to do this, right? Still get to drink water as much as I can. So in conclusion, as people do when they're presenting, talk about fundraising really quick. with that larger audience, I decided to raise some money. I decided to take the power back a little bit. So in between the 3 months of me finding out I had stomach cancer and me having my total gastrectomy, I decided to raise some money, and we raised $75,000. Thank you. Yeah, that was pretty cool to be able to do that, to be able to donate that to the various organizations in this community. And it was really, really cool. So I just want to say, again, thank you so much for everyone that has helped me through this. Thank you for everyone in this room. And I hope this has been eye-opening to some of you from what a patient's perspective is, the questions that he or they will get asked on the internet. It can be fun. And John wants me to talk about how there is a mixer after this at the hotel, the Elemental Hotel? Yeah. And then tomorrow morning. There you go. Make sure to tip your waitresses. And thank you so much.
Thank you, Sidney. And our next and last talk is Mr. Scott Brown. He's going to give another patient perspective. And please, everybody, let's give a warm round of applause to Mr. Brown here.
Sidney, you can add a +1 to your 8 million followers. At least a 1 + 1. My name is Scott Brown, and I am a father of 3 daughters. One is 10 years. 2 others are turning 12 and 14 next month. I'm married to an amazing woman who battled breast cancer 4 years ago and is now cancer-free. So I have been both a caregiver and someone with cancer. I was diagnosed exactly 6 months ago with an adenocarcinoma in my esophagus that it had been found that it had been spread to my liver as well. Not a good day, not a good day. It was a friend of mine, actually, that did the endoscopy, and she took 30 minutes to come back to tell me. And I knew during those 30 minutes that the news was not going to be good, and I started to pray. And then she just laid it on me and said, "No, I know what this is." And as luck would have it, within 2 weeks, I had started chemotherapy. I'm wearing a chemo pump right now. And so if some stuff I say doesn't make sense, then we can blame it on that. First off, I want to thank all of those on my treatment team and those who hand me pagers during chemo, those who make a poke in the arm and a poke in my port a little bit easier, and who just offer a smile. All of them are outstanding individuals, but as a team, they're amazing. And you know who you are here in this audience. Early on in this disease, and this is all within the past 6 months, I decided I would try to learn what I could from this experience and to extract as much wisdom for my mind, my heart, and my soul that I can. One lesson I learned the hard way was I went on a family vacation exactly 2 months after the diagnosis. We landed in Phoenix, and it was 111 degrees Fahrenheit, and I was wearing a chemo pump. And at 10 p.m. that night, I was sitting by the pool wearing that pump, and it was still 104 degrees. In hindsight, that was a bit of an overdue. I will not fly with a chemo pump again and land in the hottest city in America in the middle of June. But in full disclosure, we were headed to northern Arizona where it was cooler, so you don't think I'm completely insane for being in Phoenix in the middle of June. But I do have to say a few words about my oncologist. The first day I met him, he told me things I mostly did not want to hear. But the thing that he said that stuck with me was he said that he would treat me like his brother. And that stuck with me, and every time I see him, I think about that statement. Now, immediately after he first told me that, I thought, boy, I really hope he likes his brother. But I know he does. But I have hardly seen a human being, and much less a doctor, with such expertise and so humble. And my doctor is Dr. Jen. The poet Mary Oliver wrote in her poem, Summer Day, "Tell me what it is that you plan to do with your one wild and precious life." Well, now I know one additional thing that I'll be doing with my wild and precious life, and that is dealing with the big C, or cancer. I call it the big C because my cousin was diagnosed with cholangiocarcinoma 10 years ago. She's still thriving, and she called it that. She's like, "Oh, you got the big C, huh?" So that was my first conversation with her when I was diagnosed. But I also have to kind of, there is some dark comedy, I guess, with cancer. And that is that both of my parents suffer from dementia. My stepfather suffers really badly. And at the beginning, it was exhausting for me to tell my story. I could tell about one person a day about my diagnosis. And I didn't want to end up being the counselor. People would cry and weep and had all sorts of questions that I really couldn't answer. But my stepfather would come every day, and he could remember there was a problem, but he couldn't remember what it was. So I got to practice on him. I told him sometimes a dozen times in every conversation that I had esophageal cancer, and that practice allowed me to discuss it easier with others. So his disease helped me in describing my own disease. So I am very thankful to him for that. Cancer to me is not just a fight. There's a lot of kind of this ethos of fighting cancer, and certainly I have had my days of fighting it. But fighting for me is exhausting. I spend a lot of time just dealing with it without, in my mind, thinking of that I'm fighting it. Sometimes I do fight, but other times I just try to sit back and enjoy the moment that I am in, and sometimes just pray, and sometimes get to work and occasionally push out of my active consciousness that I have the big C at all. But I do not forget. The disease of cancer is an ordeal. In the first months of the diagnosis, I felt like I was confronted with this terrible choice. I could either accept what was happening, or I could reject it. And when I say reject it, I don't mean that I would refuse treatment or anything that I would just be mentally rejecting the reality of what was happening to me. In other words, you wouldn't be able to see the difference of me accepting or rejecting it. I would go through all the motions. In the first several weeks after the diagnosis, I would wake up in the morning and it seemed like all was good. And then I would remember that I had cancer. And I would literally remember it like it was this brutal experience that I had to relive when I remembered it. But once I accepted the disease, then the path forward became easier, and I cannot articulate why, but my mind and my heart were more at ease once I'd accepted it. I am an N of one, and what that means in scientific terms is that if you know one person's path with the big C, then you really only know that one person. And even if the diagnosis is exactly the same, what that person brings to that disease from all of their hopes and dreams and experience, that helps to inform how that disease affects that person moving forward. My days are probably more full than they were prior to cancer. I wake up before 5 a.m. I got up at 4:45 this morning, start the medication regimen. I pray to the Almighty with all my heart, all my soul, and all my strength every day. And I work to treat my neighbor as myself. I'll just say anecdotally that what Maya said is that diet is very important. I believe that food is medicine. Nutrition plays a big part in how I feel. I chose to go to a strict keto diet. That is because my wife decided that that was the best course for me, and she is back there in the back of the audience. I absolutely could not have done this without her, and I don't think I was the caregiver for her that she was and is for me, but I am just so grateful that she is in my life. There's a lot of ups and downs on this path. I've had, like a Charles Dickens story, it's been the best of times and the worst of times. I've had the best of news and I've had the worst of news and everything in between. I do my best not to get offended at anything anyone says about my diagnosis. I really don't think I have been offended, but I've had some people say some strange things, like, you know, because my wife also had cancer, they asked if we lived under a nuclear reactor. And, you know, who knows, maybe there was one back there and they got rid of it. But I don't have time to be offended, and I don't want to get all spooled up about anything anyone says, because most people, if they say something awkward or strange, it's because they just don't know what to say. The Almighty gives each of us grace every moment of our lives, and as parents, we give grace to our children. So why can't we give grace to each other? And lastly, I cannot emphasize too much how prayer is vital for my life. It always has been, but now I pray differently. And now sometimes prayer is just a single sigh. If you want to hear about my faith path, I'd be happy to share that with you, but that will take a far longer time than I've been given today. So I will just wrap up with a thank you. So thank you.
Thank you, Mr. Brown. Thank you, Sidney. In the last couple of minutes, I'd like to make some closing remarks. So first of all, I'd like to thank all of our speakers, moderators, the committee helping me organize this, sponsors, and of course, everybody in attendance, and in person and virtually. So I'm a physician scientist. Fortunately, I didn't get to talk about any research. So, as I said at the very beginning, I want this symposium to have kind of a vision of hope, okay? So, very quickly, I'm gonna talk a little bit of science on a higher level, and this is my kind of vision for the future and how we can cure this disease, okay? And it basically boils down to 5 important points here, okay? So number 1 is we need a better understanding of this cancer. And classically, we've thought about cancers as a tumor. We call it bulk. But what we know is that cancer cells are eachly unique, okay? And those unique properties of each cancer cells determine what treatments are going to be effective or not. And fortunately, in 2025, we now have technologies to understand these cancers at single cell resolution. Okay, so that's going to be critically important. Number 2, we need to have better predictive and prognostic biomarkers. I talked a little bit about this in my talk, but those treatments, 50% do worse than those curves, 50% do better. We don't know why. And we need better markers to figure out which patients will benefit. Number 3, we need to come up with new, what I call tumor intrinsic vulnerabilities. Basically, how can we target the cancer without making the rest of the body sick? And these are some new pathways. We won't go into the details. Number 4 is we know that especially for some of these stage 4 treatments and kind of chemotherapy, they stop working. We don't know why. And what are those resistance mechanisms and how do we overcome them is critical. And number 5, and this is something near and dear to my heart, is we don't understand how these gastroesophageal cancers develop. If we did some of those early talks, then we can truly prevent this disease from occurring, okay? So to kind of talk about the vision and kind of close off, you know, here at WashU and Siteman, we are really trying to start a foregut oncology research center of excellence. This is the mission that we have, and the vision is to kind of develop new cutting-edge treatments for patients with gastroesophageal cancers. It's founded on 3 core principles, essentially what we call multidisciplinary crosstalk, in which oncologists like myself work with gastroenterologists, surgeons, radiation oncologists, and we all work together. Number 2 is we personalize medicine. We know that everybody's cancer is unique, so we need to treat those cancers as unique diseases rather than just one big group. And then 3, and most important, we need to take what we learned in the lab back to the bench side. And we need to do this in a timely fashion. And these are the 3 most important cores. So I want to close by saying that all the talks that we've heard today are steps towards a future in which gastroesophageal cancers are diagnosed earlier, we treat them more effectively and safer, and patients dealing with the disease, we can support them with more compassion. So I want all of us together to take that trip and make those steps and take that journey together, okay? So thank everybody for coming, and safe travels. Thank you.